In the quiet waiting room of a community mental health clinic in the Midwest, a young mother sits anxiously with her teenage son, who hasn't spoken to anyone at school for weeks. She's been waiting for months to see a psychiatrist, and when the moment finally arrives, the visit lasts just 17 minutes, barely enough time to go through symptoms, let alone understand the story behind them. This scene is not unusual. Across America, families, veterans, trauma survivors, and young adults battling anxiety and depression are struggling to find timely, meaningful psychiatric care. And even when they do, the time they receive is shrinking. How did we get here? Let's take a closer look. Over the past decade, the U.S. has witnessed an unprecedented expansion in mental health funding and public awareness. Major policy shifts like the Affordable Care Act between 2010 and 2014 made mental health an essential health benefit, meaning insurance providers now had to cover it. The Mental Health Parity and Addiction Equity Act made sure insurers reimbursed outpatient mental health services at rates similar to physical health services. Then came the school shootings, Columbine, Sandy Hook, Parkland, and in their wake, political pressure pushed school-based mental health to the forefront. The COVID-19 pandemic further amplified the crisis, sparking the largest expansion of telepsychiatry reimbursement in U.S. history. On the surface, these changes look like progress. More funding, more coverage, more access. But beneath that surface lies a brutal bottleneck: the psychiatrist workforce. Unlike therapists, who can be trained in 2 to 6 years, psychiatrists require 12 to 14 years of training, from undergrad to medical school to residency, and sometimes additional fellowship. So while funding surged, the number of psychiatrists did not. According to the HRSA, from 2003 to 2013, the number of practicing psychiatrists in the U.S. grew by only 1%, and they predict a shortage of over 14,000 psychiatrists by 2030. Why? Because training slots are tied to Medicare-funded graduate medical education positions, and Congress rarely increases those. Meanwhile, foreign-trained psychiatrists face licensing delays and immigration issues. It's like building bigger highways but never training new drivers. The math doesn't work. So here's what happened: more money, plus more awareness, plus more patients, plus same number of psychiatrists, plus shorter appointments. But where psychiatrists lagged, therapists multiplied. Programs for licensed clinical social workers, LCSWs, marriage and family therapists, MFTs, licensed professional counselors, LPCs, and especially PsyDs exploded across private universities and online platforms. Walden, Capella, and similar institutions began churning out thousands of therapists annually. HRSA data confirms that this therapist workforce has grown dramatically and continues to do so. But there's a catch: when anything scales that fast, quality varies. Many PsyD and for-profit programs have high acceptance rates, minimal clinical oversight, and limited supervised training hours. It's a bit like fast food education: quick, cheap, and accessible, but not always nourishing. Still, these therapists became the backbone of American mental health, especially for long-term talk therapy. And psychiatrists? They became the med-check people. This wasn't by choice. In the 1990s, almost half of all psychiatrist visits involved psychotherapy. By 2015, that number had dropped to just over 20%, and now more than half of psychiatrists do no therapy at all. Why? Economics and system design. A psychiatrist could earn triple for 3 15-minute med checks than for a single 45-minute therapy session. Clinics pushed volume. Insurance rewarded speed. Burnout soared. Documentation took over. And so, the psychiatrist's job, once deeply rooted in relational long-form healing, became transactional. Some psychiatrists resisted this shift. One such doctor, Dr. Lisa in rural Oregon, tried to keep doing therapy. She loved her work, but she couldn't pay rent for her office doing 60-minute sessions. Her clinic administrators told her to double her patient load. After years of fighting the current, she left the system altogether. Dr. Lisa's story is not unique. Structural forces, not personal choices, drove this transformation. Layered on top of this is a cultural shift. Events like mass shootings, teen suicides, and the rise of trauma awareness on platforms like TikTok and Instagram created a surge in public consciousness around mental health. This is good. Stigma decreased. Parents now seek ADHD evaluations, autism screenings, and trauma assessments earlier. But it also created a flood of referrals, especially among youth. And guess what? all those referrals still funnel through the psychiatrist bottleneck, which means longer wait lists, shorter visits, and more strain on an already fragile system. This has consequences. Fewer minutes per visit means less time to ask about childhood, trauma, family dynamics, substance use, or suicidal ideation. Diagnosis gets rushed. Treatment becomes trial and error. Measurement-based care tools, structured questionnaires that help monitor symptoms, are rarely used. It's like flying blind, and for marginalized populations, this gets worse. A single mother working 2 jobs can't afford to wait 6 months. A Black teenager with depression may be misdiagnosed with conduct disorder. A trans youth might receive dismissive care from a provider with no time to understand their story. Injustice compounds when systems are overwhelmed. To cope, the system has adopted a split model. Therapists do the talking, psychiatrists do the prescribing. But even this model is breaking. Many therapists can't prescribe medications. Many psychiatrists can't offer therapy. And communication between them is minimal. It's a fragmented dance with patients stuck in the middle, trying to coordinate their own care across siloed providers, billing systems, and portals. So what's the solution? It starts with understanding the problem is not any one person or profession, it's the architecture. We need more psychiatrists, yes, but also smarter models, integrated care teams, measurement-based platforms, reimbursement reform, supervision standards, and above all, the courage to slow down. Because healing can't be rushed, and medication without context can only go so far. There's a powerful story about a psychiatrist who once sat with a patient for 90 minutes just listening. The patient later said, "That's the first time I felt seen. Not fixed, just seen." That's the core of this crisis. In our race to scale mental health services, we've forgotten the human soul. We've trained professionals in pharmacology but not in presence. We've rewarded speed but not connection. And we've built systems that measure cost per minute but not lives transformed. If we want a mental health system that works, for veterans, children, survivors, mothers, fathers, teachers, we must remember that care is not a transaction. It's a relationship. And relationships take time, so let's rebuild a system that honors that time, respects every profession, and brings psychiatrists back into the heart of healing, not just the prescription pad.